Alexandra, in cardiovascular studies, we've got quite hooked on MACE and hard clinical endpoints. And sometimes my colleagues will say to me, if you're an orthopedic surgeon, nobody wants to know about MACE. They just want to know about whether you're no pain, right? Or you can walk further. And if you think of as you start thinking about all the other medical specialities, you realize that we really hold ourselves to this high bar of clinical endpoints. And we've done that historically in cardiovascular trials. And I think now we're starting to realize actually quality of life and symptoms is really, really important. And in fact, if you talk to patients and you say to them, I can maybe increase your mortality by 12 months with this particular treatment, or you say to them, I can get rid of your angina and give you back your quality of life. Patients will often say actually that the quality of life aspect is much more important to them than an extra 6 or 12 months of their life. And I think that one of the things we tried to do in this trial was really focus on that. Obviously collect all the hard clinical endpoints that are important, but also collect a lot of rich data around symptomatology and quality of life.
Yeah, so we looked at quality of life, we looked at depression, which is very relevant in this patient population. We looked at angina. And for every single quality of life measure that we took, at least at 30 days, we've seen significant improvements. And I could not agree with you more. We focus on mortality, we focus on myocardial infarction, and of course there's going to be links between quality of life and those outcomes. But what is very relevant to patients and women in particular, when we have that conversation about why we need to do an intervention or a procedure on them, to be able to say you're going to have a 30% reduction or improvement in your quality of life, or a reduction in your symptoms of angina, you'll be able to walk more, you'll be able to be, you will be less depressed. And we have objective evidence for that, I think is key. What I can tell you, Margaret, from a clinical trial perspective, we're moving towards those endpoints more and more, and I think it's absolutely vital. And I'm thrilled that we included those in the clinical study. It certainly increases the burden to patients to be able to collect that information, but I think it's really vital, right, to understand how they're impacted and how they feel. So completely agree.
Yeah, and I think beyond the impact the trial will have on the IVL data and the data in female patients, I think the impact it will have in helping shift the focus towards these quality of life metrics and other trials in the cardiovascular space, I think will be impactful.
Yeah, and I think particularly, in a patient like Empower CAD is such a complex patient population, they're very, very high risk. High rates of diabetes, a lot of chronic kidney disease. I mean, you've seen this, a lot of, hypertension, hyperlipidemia. They, mostly postmenopausal women, age in the 70s, etc. Long calcified segments, up to 40 millimeters, if I recall. But, this is an important measure, for us to be tracking over time. And we're going to be tracking these not just tonight to 30 days, but also long term, 1 year out to 3 years. So I think it's going to be really informative for the patients.
I agree. I think the other thing is that, often when we get new technologies, we very prescriptively design these clinical trials to really hone in on a very specific patient population with specific morphology and anatomy. And I think that this is a really rich data set because there's a lot of heterogeneity in the anatomy and in the, as you say, very high prevalence of all the comorbid conditions. So I think this is a different thing altogether than what went before with Disrupt. Yeah, it's going to be give us a completely different real world perspective.
Yeah.